Now I want to hand over, if it's okay, to Professor Caitlin Notley and Dr. Ian Pope from the COSTED team, who are going to give us provide an overview of the trial and in particular its findings, which are very, very interesting to say the least. Thank you, Ian.
Thank you very much, Alan. Excuse me. Hello, I'm Ian Pope, and I'm going to be sharing, along with Caitlin, the results of the COSTED trial. Great. So yes, so a bit of background. There are 25 million ED attendances each year in England, so lots of people come through our doors every day, and those who attend are more likely to smoke. From our pilot work, we think it's between 20 and 25% of people who attend ED are current tobacco users. So we think ED represents a really valuable teachable moment. People are sat, bored, thinking about their health, so we think this is an exciting opportunity to intervene. Just picking up on something Dominique said, thinking about inequalities and who comes to ED, this is ED attendances by deprivation decile, and we can see that the most deprived 10%, about half of them will come to ED every year. And so actually, if you're trying to reach that most deprived decile, ED is a great place to reach them. So when we started thinking about the COSTED trial, there was lots of pushback that actually ED is the wrong setting because that people are too unwell. And this is what people imagine happens in ED. However, this is the reality. There's a lot of waiting. There's a lot of time when things aren't happening and people are just sat. So actually lots of opportunities to intervene. So COSTED was a 2-group randomised controlled trial, 6 emotion departments across the UK. We aimed to recruit everyone who came to the ED who was a current smoker, so anyone who smoked at least 1 cigarette per day who was attending ED. And we weren't particular at all. We were trying to reach those who were the most underserved. So we recruited people who were experiencing homelessness. We recruited people who were there with complex mental health problems. We really were as broad as we could be. The intervention was brief advice, so 15 minutes, tailored to why people had come to the ED. So thinking about if they'd come with a laceration, talking to them about how moving away from smoking might impact and improve their wound healing. We then provided them with an e-cigarette starter kit and provided some training and 15 minutes on that, so half an hour in total in the ED, and then we also referred them to local stop smoking services. Control was written material about local stop smoking services. We screened people in the ED as might happen if it was implemented as normal practice at reception, just as part of those standard questions asking, do you currently smoke? And that obviously gives you the opportunity to get lots of details, lots of data on people who currently smoke that can then be linked to other health records. We then consented and randomised them. And then those randomised to the intervention received it whilst they were waiting. We then followed them up 1, 3 and 6 months later. And the primary outcome was biochemically verified smoking cessation at 6 months. Just to say that this was much harder than we anticipated. By the very nature of the population we recruited, actually getting people to come back for their carbon monoxide test was really difficult. And we were obviously spread over quite a large area, so it was really challenging because of the nature of the population. So we screened about 1,400 people, really great uptake. People were really keen to take part, much more so than we expected. So we recruited very quickly, 1,000 participants, 500 in each arm. Yes, and we, as I said, we closed the trial early because we recruited quicker than expected. So who did we recruit? 60% male, mean age of 41, 73% white British with a good range of other ethnicities, and 28% were unemployed or unable to work due to ill health. And this is our breakdown by IMD of who we recruited. So 28% were in core 20 and 66% were in IMDs 1 to 5. So again, picking up that actually if you're trying to reach those more deprived deciles, actually ED is a great place to reach them. And here are the results. So this is the biochemically validated. So this was people who we managed to get hold of who came in for their CO verification. and 7.2% quit rate in the intervention group at 6 months and 4.1 in the control. So those who received the intervention were 76% more likely to have a biochemically verified quit 6 months later. So a really exciting result that we found that difference despite some of the challenges. And this is the self-reported data, which I think in many ways probably is a better reflection of the true quit rate. The truth is probably somewhere in between, but so really exciting that 23.4% of those in the intervention group reported having quit. So a quarter of them went on to quit 6 months later, compared to 13% in the control. And again, so if you received the intervention, you were 80% more likely to report having quit 6 months later. So a really exciting result and a really significant difference between the groups. Just thinking about implementation, so thinking about Norfolk, so we have 3 EDs in Norfolk and Waveney with about 290,000 ED attendance each year. So if we implemented it at all 3, we think that, so there are about 20,000 people who smoke who would attend whilst if we were operating 9 till 5. And if we, based on the data we have, you'd expect about 1,600 extra quits per year as a result of implementing it in the 3 EDs. Thinking about cost, so if we work on the basis of 2 whole-time band 4 members of staff at each of those EDs, we used a whole variety of members of staff, but I think so tobacco dependency advisors of some description in the ED. We obviously were using some research staff, so a wide variety. Then obviously the starter kit, as Alan said, that could be covered by swap to stop. So that gives a cost per quit of about £133, so very cost effective, and we undertook an economic evaluation which again showed that this is a very cost effective intervention. So some key messages. So it's possible to opportunistically reach large numbers of people who smoke in the ED. You can reach a population who wouldn't otherwise engage. These aren't people who are about to turn up to your stop smoking service. The costed intervention works to help smokers quit, and it's a great setting for swap to stop. Thank you very much. I'm going to stop there and hand over to Caitlin for some more results.
Thanks very much, Ian. I'll just share my screen. Can you see my slides there in slide view?
They're in, we can see it's not in presenter view, Caitlin.
Thank you, that's better.
That's it, perfect.
Okay, so I'm just going to talk you through now some of the findings from the process evaluation element of the study, and think specifically about lessons we can learn from the process evaluation for implementation of this trial. So the process evaluation, we aim to undertake an embedded study looking at the way that the intervention was delivered within the setting of the emergency department, any lessons we could learn from implementation, and we specifically wanted to understand whether there was fidelity to delivering the intervention as per protocol, and look for any signs of contamination between the control groups. We did this using a range of methods, by asking people questions in the follow-ups that we undertook. We did ethnographic observations at each of the emergency departments to look at the context for delivery. We also undertook qualitative interviews with smoking cessation advisors involved in the study and with participants across the intervention and control groups, a selected subsample. And we analysed the data using thematic analysis and triangulated the learning from those different data sources. So in terms of the interview samples, we spoke to participants and advisors from all of the emergency departments that took part in the study. We had a good subsample of participants that broadly reflected the population of people we recruited for the main trial, and also a range of advisors. As Ian said, we spoke to advisors who came from a clinical background and perhaps had been seconded to the study in a research role, but also healthcare assistants and clinical research assistants who were delivering the intervention for us. So the first finding to talk about in terms of implementation is the concept of adaptability. So we saw huge variation across the emergency departments in the way that the intervention was actually implemented. But despite that difference across the sites and the range of different emergency departments that we observed, we actually found very similar rates of smoking cessations across the sites. So the conclusion really from our observations was that staff and participants were making quite flexible adaptations, and this was really important to ensure successful intervention delivery. The emergency departments are really frantic, frenetic environments, and often advisors had to deliver the intervention in different settings, in the waiting room, outside, in a side room if possible, but it wasn't always possible due to space limitations. So there was huge adaptability, and sometimes we even saw instances of the intervention being delivered in two parts. For example, a participant might have to go off to receive results of a clinical test and would come back to the waiting room and receive the second part of the intervention. So really key when thinking about implementing the intervention was the adaptability of the advisors to be able to work within the patient pathways. It was really important that our advisors, not part of the clinical care teams, but did fit in alongside the work that was going on within the ED and could be very flexible, because obviously the clinical interventions that were necessary in the ED always had to come first. They had to be very adaptable in finding space for intervention delivery. We will all know from the news in the last year that emergency departments are hugely under pressure. Space is at a premium. So often our advisors worked in the quiet corner of the waiting room, using a side room, or were really adaptable in terms of where the intervention was actually delivered. And we also saw really flexible use of the intervention manual. So although our advisors had showed high degree of fidelity to delivering the intervention script as we proposed it to be delivered, they were also really flexible in deploying that. So, for example, they may have to adapt the language they use depending on the level of literacy of the person that they were delivering the intervention to. In terms of the context, the response of participants, of patients to the intervention could vary. A&E attendance is naturally a time of really high anxiety. Some people are there in significant pain. Some people didn't want to be approached. And obviously within the research study, that was absolutely fine. People gave informed consent to take part in the study. But actually we saw really good uptake of the intervention beyond what we had expected. What we felt was that the context actually was quite facilitative of being part of a research study, but also of receiving the intervention. People were waiting often in the emergency department for a very long time. They were bored, and that kind of waiting time facilitated the acceptability of just chatting to someone about something else to take your mind off the reason you might be attending the emergency department. So being distracted from the pain or alleviation of that boredom could really motivate participation, and was a key reason that people agreed to take part in the study and were amenable to receiving the intervention. So just a few quotes here from some of our advisors and from our participant, talking about those aspects, being adaptable and being alleviated from the pain and boredom of sitting in an emergency department. In terms of the clinical staff buy-in to the study, in our observations showed we had really good commitment and buy-in from the advisors delivering the intervention. We trained those advisors, they were really on board with the importance of smoking cessation and really adaptable and able to kind of tailor the advice depending on the presenting patient. But it's fair to say there was a variable reaction from some other staff in the ED. Some staff were really supportive and could refer patients to us to take part in the study. Others showed some resistance, perhaps viewing the intervention as a bit of an obstruction. So clearly on implementation, it's really important to build those relationships with the clinical staff so that they understand the importance of intervening in this setting and the cost savings of the intervention in terms of healthcare in the future through managing to support people to quit smoking. So a quote here from the advisor just shows that it's easier perhaps to implement this where the clinical teams are really on board with the importance of the intervention. So there's some relationship building to be done there perhaps with implementation. In terms of the way that the intervention was found to be actually working, we did some analysis looking at the mechanisms of impact. So looking at the kind of behaviour change techniques that we'd built into the intervention script and the ways in which those behaviour change techniques might be operating to work to change the behaviour of our participants. One of the key findings was just around the opportunistic nature of the intervention. Many participants told us in qualitative interviews afterwards that it was just the right time and the right place. They were amenable to thinking about stopping smoking. Perhaps they were really thinking about the reason that they had attended the emergency department, if that was a smoking related illness, particularly having the intervention at that time and that of heightened health awareness really meant that they were in a frame of mind able to contemplate change. This participant here talks about being aware of their own mortality, sitting in the A&E and thinking about their future health behaviour, for example. Another aspect of the opportunity and the way that the intervention was acting is that many of our participants were not motivated to quit smoking. They weren't people who were attending a stop smoking service asking for support. Perhaps they'd never really thought about quitting smoking, and some people told us that they'd never really been approached by anyone about smoking cessation before. So again, that opportunistic approach just happened to catch people at the right time and the right place. Another aspect of the way the intervention might have been working is around providing people with the capability. So this was the aspect of the intervention where we advisors showed participants the e-cigarette starter kit and talked them through how to use it. So they helped them feel capable and able to go away and give it a try. So participants, some of them told us that they had been unsure about using e-cigarettes. Perhaps they'd seen negative press and were concerned about e-cigarettes, but having the intervention delivered within the setting of the emergency department provided some reassurance about the e-cigarette as being a harm reduction approach for smoking cessation. And particularly having the intervention delivered from what was perceived to be a credible source, a healthcare professional within a healthcare setting, we think was a really important aspect of the intervention. It gave people the kind of reassurance that they perhaps needed to give it a try. For some people, motivation was really key. Having smoking cessation discussed in this setting and the style of the intervention, some participants told us it was just the kickstart that they needed. The intervention was very low pressure. We talked about switching away from using tobacco rather than quitting smoking and just encourage people to give it a try. Also, giving people the actual e-cigarette starter kit there and then meant that they were able to give something a try straight away, and it gave them the kind of practical impetus to make a change. In terms of support, the way in which the intervention was delivered, again, was meant to be very kind of non-preachy. And the feedback we had through the process evaluation interviews was that it was caring and a positive approach. So sometimes participants told us that it was really nice to be just chatted to by someone who seemed to care about their health. Which was really nice feedback to receive, but also an important aspect of implementation, thinking about the kind of framing of the conversations that we have around smoking cessation. Some barriers to impact of the intervention. Clearly, e-cigarettes or e-cigarette-based interventions are not a magic bullet. They are not for all. Some of our participants had failed quit attempts, particularly because of local product availability. So if people weren't able to purchase ongoing supplies, perhaps that might be a point at which they were vulnerable to relapse back to smoking. Suggesting possibly, if implementing this in the world, some kind of light touch follow-up might be helpful for participants. Other people reported trying the vape but finding it ineffective, so clearly people might need ongoing support to try different devices or try and use different flavours and strengths to find the one that suited them. And the referral aspect of the intervention, as Ian said, we referred all of our participants in the intervention group to the local stop smoking service in their area, was unfortunately a component that was rarely taken up. only approximately 3% of our participants took up that referral. So this really indicates that this was a population where alternative approaches and perhaps more active outreach and ongoing support might be needed. We did pick up a few unintended consequences in terms of the contamination between the groups in the study. I guess really positively in terms of implementation, our advisors got really on board with the importance of smoking cessation, and sometimes they couldn't help but talk to the control group participants about e-cigarettes or encourage them to attend the Stop Smoking service, perhaps beyond what we would ideally like to see within a randomised controlled trial. Obviously, in the real world, this isn't an issue, but for the trial findings, it suggests that perhaps we might have seen a slightly higher rate, quit rate in the control group than we would normally see in the general population. And then other very positive unintended consequences, I think this is a really important point for wider public health, is that many of our participants talked about others in their family, perhaps their partner, trying out vaping because of their involvement in the study. And 12% of our participants reported directly that friends or family had actually gone on to quit smoking and switch to vaping as a result of their initial participation in the study and being aware of the e-cigarettes. So there's that important kind of ripple effect of other people within family and social networks going on to quit smoking. And then the final point in terms of positive unintended consequence, as part of the trial, we did follow up participants using text messages. So we got in contact with people at 1, 3 and 6 months to ask them their smoking status. And although that was a research measure, and we actually picked up through the process evaluation that this was really perceived and experienced as an aspect of support. So it might be something to consider in terms of implementation, a very light touch follow-up by text message, because participants found it quite motivational that someone was checking in on them and asking how it was going. So that's it from me. I'm going to hand over now, and hopefully we will be able to hear from some of the participants who actually took part in the study.
Well, I've been smoking since I was young. I tried to stop, I don't know whether the first after, that little tube, tried the patches as well, but didn't get nowhere with them. So when I was like, I'm 46 now. Back in 2005, I actually ended up having part of my lung removed, and through that I was in hospital for quite a long while. I was having help with patches. I think it was about a year I stopped. I suffered long term with this sort of mental health, and I just went through a really difficult stage in life, and I then just, reached back to the tobacco.
I tried when I stopped previously patches. I mean, I was still, when I started smoking, I was still using the patches, but I was actually taking the patches off to have a cigarette. To me, the patches didn't work.
I was aware before about the possibility of vaping available on the NHS. If that comes along, then that is something I would like to try. When I was approached in A&E, it's like, yeah, definitely. So I was sitting in the waiting room. A nurse came out. She said that she'd looked at my nose and she saw that I was a smoker. Could she have a chat with me? She said, maybe take an hour, and I had another 2 hours to wait for the blood test. I was like, that's fine. I've personally been thinking about trying to quit smoking at some point. I had put a lot of thought into it or made any attempts at that stage. Like, it was kind of like, this could come in handy later on. Just sitting down in A&E after the lady spoke to me, like, let's stop smoking. This could give you a try back. It's a program for 6 months to try and see how you go. Why not start on young? I've got to try it. The main thing was, the lady said, it's up to you and it's your choice. It's just like you're given an opportunity to actually decide for yourself. No one's ever said that, except kicked in. There was no pressure, but the way that she approached it made such a difference, as opposed to, I think, like anything, if somebody tells you
You have got to, or you are not developed.
I struggle with strangers, so I felt that it was a little bit daunting sort of situation, but they really put me at ease straight away. I did feel comfortable. I guess being in the hospital, it was sort of like a lifesaver as such. And I think because, you know, I had to continue, I had no option other than to do that for almost a week, that by the time I then got out of hospital, I was then sort of used to it. I came home and that was one of the first things I'd done. I put my papers and I boxed them all up and put them in the back of the drawer and continued with the vape.
When I was chosen, you know, and I got all the stuff, and I take it away and said, but I can't promise that I will do it. And you know, that's how it was left. When I came home, I put it in the bottom of my walk-in wardrobe, and actually, it right out of my mind. It was actually the following Sunday. I thought, I'm going to take this out and have a look. And I took it out and I sat and read all the stuff and took the vape out the box. I thought, I'm going to do that tomorrow. That was it. But there's twice that I'd like, I could do with a cigarette. Within about a minute, 2 minutes, I just get the vape and I, you know, go help the leather with the vape and that passes.
I didn't admittedly start using the e-cigarettes right away. Carried on smoking, kept the bags. On the day of the Queen's funeral, I had ran out of cigarettes the day before, all the shops were closed. So I essentially turned my house upside down. And then I came across the bag and I thought, tried that off cold turkey, and I went straight to the e-cigs, and I haven't smoked a cigarette since that day.
I was in the hospital, then my tobacco finished, then I thought, hey, hold on, how was the day? We need to go buy more tobacco. Let's do the vaping, see how it goes. From there, I'll be honest with you, I stayed with it.
That was pretty straightforward, that e-cigarette. I mean, that's one of the reasons why I liked it, because it was so straightforward. I mean, it's just a clicking cartridge and then inhale pretty much. And if it doesn't work, charge. And you know when it is charging because it's got the flashing indicator. So.
You know, not even having to sort of press a button even, and it was just easy to change, didn't have to fill with a liquid or things. I was really impressed.
There's so many people that have actually asked me about this particular vape, because they tried my vape and they actually went on and ordered kits because it's not a big vape, you know, it's light.
It's a lot less expensive as well on a weekly basis. Like I smoke roll-ups, it's £17 something, a lot of money. While with the vape, it's £6 something for 2 little pots. And that's like when you really crave for a cigarette or anything.
So through the worst time in my life, Don, I am so shocked, but really proud as well that I was still continuing to vape. I don't feel you owe me any thanks for taking part or succeeding. You know, all the thanks comes from me, because I know you have done me, you know, a huge service.
My GP, who I've known for years, she said, I'm just going to read what the renal specialist has said, and one of the things is stopping smoking. I said, I stopped smoking 5 months ago, and she couldn't speak, and she went quiet, and I said to her, are you still there? She said, I cannot believe this, and I'm so proud of you.
Thank you, Caitlin. I don't know if you want to say any more final words before we move on.
I'm really happy to answer questions, but I think we're going to move to the case study next, and then we'll perhaps take the questions at the end.
Excellent.
Yeah, good plan.
Thank you for the overview of the project. fantastic, really great results there for us to maybe come back to at the end. But also the value of that little video clip with all of those the voices of the clients. That is really powerful stuff. So thank you very much for putting that together, and obviously thanks to them for providing those words of encouragement and support as well.